Morning, everybody. I'm Mike Briones. This is Rachel Swerdlin. She's Matt and I call her our boss, actually. So she takes care of us in our multidisciplinary clinic. We really appreciate you inviting us here. It's a privilege and it's an honor, especially to take care of the patients and the families that we do. And so thanks for inviting us. So we were asked to give a talk about how we started our clinic, our Vascular Anomalies clinic in Atlanta. And I'm going to give you a little bit of the history of where we were at and where we're at, and Rachel will finish where we're at now. And it took a lot of people, took a lot of hard work and meetings to get this thing going. And we're really proud of it. So why do we need a comprehensive vascular anomalies program? Well, it's really you guys. It's the patient and the families. Really needs dedicated physicians who know about the disorders that you have and fully take care of the whole body. And so it's really the patients that we take care of. And this is actually the same patient that Matt actually touched on when he was reviewing his radiological findings for GLA. So this is a 4-year-old male now, and he presented at 3 years of age. He fell on a brick wall and hit his right side against the wall. Notice that his right chest was indented. The parents noted that, and his right side of the abdomen was a little bit bruised and swollen. Went to a local ER where they noted multiple rib fractures bilaterally, not just on the right side, and his right chest was full of fluid, which they presumed was a hemothorax. He had bilateral pleural effusions, right greater than left, and they placed a chest tube. He came over to us and he was intubated, sedated on ventilatory support. So initially they were working him up for non-accidental trauma, and they put another chest tube on the other side. We actually, Matt had mentioned that our radiologist, Sarah Mila, who is part of our vascular anomalies program, read the chest x-ray and then kind of notified everybody in our group that, this is not non-accidental trauma. And so we all actually got together and talked about it, talked about the patient, and everybody was consulted. The PICU consulted us. So we recommended the whole body MRI, a biopsy of a representative lesion. And so this is the pathology. This is actually the biopsy, and you can see these thin-walled vascular vessels within the bone, and that should not be there. And this is just a few more of the pictures here. You can see that there are these, some of these vessels are filled with blood. You can see the red blood cells in there. In a little bit higher power view. And we did, our pathologist did D240 staining, which was positive for lymphatics. And so the diagnosis with radiological findings, the pathology, we diagnosed him with GLA. So this was his chest x-ray coming up here. You can see that the right chest was full of fluid, also the left. And on a closer view, you can actually see the kind of the moth-eaten ribs and also the sternum. And then you can see the vertebral bodies that are affected, and then also the sternal bones that are affected. So, like I said, he was diagnosed with generalized lymphatic anomaly. We started him on sirolimus and Zometa. He was able to wean off the ventilator within a few weeks. And actually was discharged home. It was a long hospital course. It was almost probably 2 months before he actually left the hospital, and then he followed up in our vascular anomalies clinic. And right now he's being maintained on sirolimus and Zometa. And then this is his chest x-ray, one of a recent one. He still has a really small right-sided pleural effusion, but overall it is much better. You couldn't even tell that he has this. He's just running around playing. So I started at Emory in 2000, coming out of fellowship, and I did leukemia lymphoma for the longest time, and I didn't know vascular anomalies from my, all I thought it was a hemangioma, right? That's probably my thinking back then. But until recently, the state of Georgia and the immediate surrounding area had no vascular lymphatic center. That we felt that there was a growing need, as many patients are being seen at other centers. In Emory, we're one of the largest pediatric oncology groups in the country. I think we're probably either 1, 2, or 3, always in the top 3. We see about 400 between 450 to 500 new oncology patients a year. We have the largest sickle cell program in the country. We're the #1 hematology. We see the most hematology patients in the country, but we don't have a vascular anomalies program. So it was, to be honest with you, it's a little embarrassing. So we did not have a formal program in place to manage and monitor the care of the patients with vascular anomalies, lymphatic anomalies, and AV malformations. And we wanted to improve and coordinate both the outpatient and inpatient care for patients with vascular anomalies. So what we had in place back then was we had no clinic, there was no center, there was no access points for the patients, there's no programmatic resource, there was no clinical guidelines, there's no research going on. We actually met, Leslie Lawley, our dermatologist, she actually set up a meeting probably once every 3 to 4 months, and we would meet and try to go over cases that we thought we needed to review. So that was our kind of vascular anomalies program back then. And it was kind of haphazard. We met when and where we can without any support. So, one meeting maybe at a different location, the next one we'd have to move to a different one, so it was just tough. And we didn't get any help from our administration. So what happened? What made the change? Well, Matt came on in 2014. He's a pediatric IR. We didn't have a pediatric IR person dedicated to this. The pitch, right? So it started with help from very influential supporters on our behalf. I mean, that's the bottom line. My department chair usually doesn't call me. The only time she called me was when I refused an admission on a patient, and she told me, "You need to admit this kid." So that was the only time she called me. But she called me with this question: why don't we have a vascular anomalies program? Okay, and I go, "Oh, yeah, okay. Well, you guys didn't want one when we asked for it." So we finally met with the Chief Operating Officer of Children's and the Chief of Pediatrics, and Matt and I actually had a meeting with them when we made our pitch about how we envisioned this program. So this is what this is where our patients went to, right? So these are the well-established programs, Cincinnati, Boston, Philadelphia, Arkansas, Wisconsin. This is where, when we started this is where our patients went to, and there was no one really around the Southeast that our patients couldn't go to, and so it was really needed. So so we made somewhat a mission statement. We want to provide the state-of-the-art evaluation and treatment for rare conditions that affect the lymphatics and blood vessels of any part of the body. The multidisciplinary team provides comprehensive care for complex vascular lymphatic conditions using the latest IR, surgical, laser, medical technology, that we have to offer our patients. We feel that the multidisciplinary approach is very important. We all know that GLA, GSD, and KLA can affect multiple parts of the body and multiple organ systems. And the disease processes are complicated enough to where it requires perspective from multiple members. Each physician relies not just on his or her expertise, but much more on the expertise provided by the other members of the team. And you know, when we have our conference, I'll get called out if I say something stupid or it doesn't make sense. So it really is a really good working environment. So we are always thinking about the patient and thinking about what's best for the patient. It really does improve coordinating resources and minimizing communication failures, can route patients quickly and efficiently to appropriate therapeutic regimens, and thereby optimizing outcomes. It increased provider awareness about new research in the related field. So, you know, Matt or Steve Gowdy, our ENT, will discuss a new procedure that we could offer these patients. So it's really it's a wonderful thing. So when we starting this program, we had to show them how many patients that we've seen, each of us. So we had to kind of look up the ICD-9 codes for all the disorders and count how many patients that we could actually see in our clinic. And so that was one of the things we had to do. We had to figure out where the money was coming from, right? And so we had discussions with my division director, the hospital leadership, radiology leadership, who was going to fund this program. But as we were talking about that, you know, our pediatric surgery department actually had a vascular anomalies program concept in their strategic plan, but no one actually kind of took that on, so it was just kind of there. So, so we said, well, you know what, if they've already have it in their strategic plan, let's take advantage of it and use those resources to start it up. So we partnered with the Division of Pediatric Surgery to develop the Vascular Anomalies program. So the nuts and bolts, we developed a strategic guiding team. So Matt, myself, our core group met regularly. We sought advice from established programs. You know, everyone here, all the leaders here, we kind of picked their brains. We've gone to their programs. We looked at how each of those programs work, and we kind of took the best from each of them and what we thought was the best from each of them and kind of made our own program. So we developed a core team. We had buy-ins from subspecialty groups to identify specific members for our vascular anomalies program. We named a director. Matt Hawkins is our director for our program. And the concept was we would have a core team in clinic, and these physicians would be there all the time in our clinic, and then we would have also other subspecialties that are going to be the point person for if we needed pulmonary or orthopedic or whatever help we need. These are the things that we asked for: nurse practitioner, nursing schedulers, all those things that kind of run the clinic. We've got that, and then also the space. So I'm going to stop there and have Rachel kind of take over and see how our clinic is now working. So.
Thank you again. I'm Rachel. I'm the nurse practitioner for our clinic. So like Mike said, this is kind of where we started, and after they got the clinic approved, I think the next step for them, besides finding the doctors, was finding the nurse practitioner that would actually be the face. So I actually got an email. I worked with Matt before in a different role in my previous job, and he was like, do you know anybody that would want to be the nurse practitioner for the Vascular Anomalies clinic? And he sent it to a bunch of nurse practitioners, and I responded to him, and I was like, what's a vascular anomaly? And I may be interested. So like many of us, we didn't even know what vascular anomalies were, but just after 2 years, you can learn so much about vascular anomalies. So obviously I took the job, and here we are. So this is our team. I'm the nurse practitioner. I'm not going to go through all the people, but we do have a nurse. She's a part-time nurse, and we've asked for another full-time nurse because we're growing so fast. We need more help to keep up with the day-to-day operations of the clinic. We have dermatology. It's going to be started in our clinic next year. Right now, our patients get referred to Dr. Lally. IR, hematology, ENT, plastic surgery, general pediatric surgery, radiology, and pathology are all the group that's there in clinic every week. Our radiologists and pathologists aren't physically present, but they come to our conference, which I'm going to talk about in a couple minutes. And then we have what we call our consult team, or the subspecialty team. These are doctors that we've identified who have an interest in vascular anomalies, and they're invited to our conference that's every week after we see our patients, that we can WebEx, kind of video conference in. But they know about vascular anomalies, they know about your diseases. So it's really helpful to have that team, because if one of our GLA patients has pulmonary issues, having pleural effusions, we know that we can send them to Dr. Simon, who knows about your disease and knows what GLA and Gorham-Stout and KLA is. And a lot of times to get to people, other physicians, can be a long process, and you have to wait several months for an appointment. But the benefit from being in a vascular anomaly center is that I can call that doctor and be like, we need to get this patient in right now. Can you get them in like next week? And I usually have much more success doing that than if you just tried to get an appointment with that doctor. We also set up some research. We were started based on clinical providers that don't have a lot of research experience. So we wanted to set up some research infrastructure to help grow our clinic and learn more about these diseases. We developed collaboration with some basic scientists at Emory and at Georgia Tech. We have a tissue biorepository, so any patient that gets a biopsy or a resection of their lesions get tissue banked. It's through our pediatric hemonc biorepository, so that those specimens are available for research later on. We have an overgrowth genetic panel that can be run at Emory, so that's been helpful, not having to send specimens out of the state, and helps with insurance, getting approval and everything. We do keep a REDCap database of all of our patients, so we have that information with everybody's labs and all the clinical information readily available for when we're ready to do research projects. And then we collect quality of life information on all of our patients that are over 2 years old, using some PedsQL, which is a quality of life tool, and a pain instrument as well. In the past 2 years, we've already started doing some abstracts, and we've gotten some grants. This is just a list of some of the things. We were at the ISFA conference that was just a couple months ago, had 3 posters, and Matt gave a little short talk as well about some of the things that we've been working on in our clinic. We're also now part of the Lymphatic Anomalies Registry through Boston Children's, and we're starting to enroll patients. I think we've had 2 enroll so far. This just started, I think, in June. And then we've received a grant that our Georgia Tech researcher, Brandon Dixon, got, that's tissue engineered lymphatic malformations on a chip for screening therapeutics. So that's going to be really interesting coming down the line, looking at how lymphatics respond to different medications that they can look at on a little chip. And then we're part of some clinical trials as well through Denise Adams. So this is kind of how our clinic looks. We have we have meetings where we review all of our patients. We have research meetings. We have strategic meetings where twice a year we kind of update the whole team on how the clinic's doing, what can we do better. For our clinic, we have the full-time nurse practitioner. We have our .6 nurse, which is a part-time nurse. Right now we have clinic on Mondays. We're about to move to a new building with new space, so we can have a full-day clinic with a lot more patients availability. I have my own clinic where I see a lot of the follow-up patients that I see I do 1 to 2 a week, actually. And then for our future plans, in September, October, we asked for that nurse, move into the new building where we have more clinic space. These are the type of conditions we see kind of with the numbers. It's not totally accurate, but it's close. Hemangiomas are obviously what we see the most as the most common vascular anomalies. But you can kind of see we do have 13 patients with GSD, GLA, and CCLA. We actually don't have any KLA yet. And then a lot of patients with the complex, I just kind of lumped them all together with all the overgrowth syndromes and CLOVES and Proteus and Klippel-Trenaunay syndrome. This just shows the growth of our clinic in 2 years. We started in May of 2016. We started with clinic every other week for about 3 months, and then we moved it to every week. They were half-day clinics. The first graph in red is the number of patients we saw at each clinic. So you can see how much we're growing. We started seeing 12 to 13 patients in a month to seeing up to, I think our highest was 88 1 month patients we saw. And we keep growing and growing. I get, 8 to 10 new referrals a week from all the different diseases that we see. The second graph also shows the number of procedures that we're doing. We do a lot of IR procedures. Surgeries are a lot smaller number, but it's definitely growing, and you can see the rise in the IR procedures that we're doing as well. We did add a second interventional radiologist, an interventional radiology room at our institution, so that's part of the increase as well. So moving forward, we want to continue to develop our research program with our researchers Brandon Dixon and Jack Arbeiser, who has a hemangioma interest. We are part of the consortium in pediatric hematology oncology for vascular anomalies that was just developed. We are working on getting a clinical research coordinator because I can't do the research and the clinical aspect. We are working with CHOA and Emory on what we can do for the adult patients once they age out, and we do get a lot of calls from adult patients like, can you see us? And we can see patients up until 21 or until they turn 22. There's a whole process of getting an extension, but you have to have a plan of how you're going to transition them out. So it's not like we can just keep them forever, unfortunately. We would if we could. So we're working with Emory to figure out, is there somebody that we can transfer these patients to? We have people on the IR side, but we're working on the oncology side as well. And working with the hospital to extend their age limit for these diseases that don't have adult options. And then in the far future, at some point, we would like to have a vascular anomalies inpatient service. It's a little difficult right now. Our institution has 2 different campuses that are about 20 to 30 minutes apart from each other, and our patients end up at both hospitals, so it's hard, but we are building a new hospital that will be ready in about 7 years, so that's kind of exciting. This is just our webpage of, if you went to www.choa.org/VAC, this is what you'll find. And just a special thank you to Danny and Tiffany Ferry, Jack Kelly, our team, and our patients.